Am I audible
yes,
now?
it has, yes.
I think we shall discuss about the definition, why it gets missed, issues on presentation, the challenges for treatment, the complications, outcome, and the learning points. And if you look at the definition of spinal injury, then late presentation, usually more than 3 to 4 weeks, is supposed to be neglected spinal cord injury. However, it is different in different parts of the world. And in the developed world, if it is missed in the emergency room or in the initial presentation in the hospital, then it is neglected. However, in India, and our developing countries, there are various causes I just discussed. It could be missed, it could be delayed presentation or poor treatment on initial presentation. So, and as I said, Dr. Chabra has written a book on this, and from there I took out some of the literature and epidemiological patterns. And the cause for delay in our developing countries is rural backgrounds, lack of infrastructure, lack of skilled surgeons, unawareness, poor socioeconomic status, lack of transportation. And as I was just saying, that if you look at this study, 25% of patients would present after a month of injury, and only 18% would present within 24 hours of injury. And if you look at this long-term study where they looked at spinal cord injury, and if you read from bottom up, 6 patients died as a result of delay in diagnosis, 9 patients had complete paralysis, 26 patients had neurological deterioration, 34 patients had inappropriate intervention risking neural injury, and the most common level was subaxial spine. So there is an issue with delayed diagnosis and delayed presentation, and the treatment is difficult. So I asked when Dr. Srivastava asked me to talk on this, so I asked my boys and our secretary to pick out our data, and I looked at from 210 to 2010 to 20, and we didn't have a lot of cases. We had 186 cases of cervical spine trauma, and interestingly, 30 were neglected, and that surprised me that about 15% is neglected in our series also. And 12 were initially treated elsewhere conservatively. So the orthopedic surgeon who saw the patient didn't think seriously of this injury. 2 were referred from other centers later. 7 patients had neglected themselves and presented late because they think the neck pain would go away. 9 patients, the diagnosis was missed. So we had a full spectrum of this. And what are the problems of neglected spinal injuries? There is progressive neural deficit, there is progressive deformity, persistent pain, prolonged morbidity, early mortality, and then medical legal implications are now more and more. However, in some patients, you can have spontaneous fusion due to delay. And that also is an interesting thing in our country, because sometimes purged facet, fractured facets can fuse and may have minimal problems, and there could be a kyphosis, and you need to discuss with these patients. So that is also there, another aspect which we need to think about before we offer them surgery. So what are the main causes? Missed diagnosis, especially in patients with polytrauma, obtunded patients, head injury, facial injuries, and other injuries which are more life-threatening, then the neck can get missed. Late presentation by the patient himself, because he treated himself or he went to an alternative treatment, or unable to reach the hospital due to lack of funds or transport or distant area where he lives. And early discharge or inadequate treatment by the hospital where he presents, whether due to finance, beds, priority, by the doctor being unaware, or by the patient or relative these days having lack of confidence in the treatment proposed by the surgeon, because there is a little bit of mistrust these days. So why cervical spine injuries are easily missed? Because you have a various group of patients, and then the radiograph, which is most commonly taken, may not be appropriate. And we teach our students always to have an appropriate cervical spine X-ray. As you can see in this, the short neck, when the shoulder is pulled down, then you can see a purged facet. And this was missed in Delhi itself. And this was one of my ex-school classmates. So, I got this X-ray out, and so this is a problem. What are the other common fractures which are missed? One is odontoid fracture, because they have minimal neurology and they can be missed. Teardrop fractures, as you know, can be in flexion, which is more serious, or can be in extension, which could be missed. And they have minimum symptoms, the teardrop fractures in extension, but could be unstable. And especially in Angst-Pons, you have to be very careful. Facet dislocations, unilateral of fractured facets can be missed. Hangman fracture is another thing which can be missed when there is minimum displacement, and they can be ignored because they have less symptoms. So It is imperative that when we are referred or asked to see or must teach our boys to do a proper clinical examination, to have the appropriate radiographs and do a proper interpretation of these radiographs as well. And if any doubt, then do furthermore investigations. These are the routine X-rays that we do: cervical spine AP, cross trabal lateral, odontoid open mouth, and I think all the people watching this presentation would know that this is very important. The cervical lines, the anterior, the posterior, the articular pillars, the spinal laminar line, and also the interspinous line and the posterior spinous line. And the soft tissue thickness in front, because the soft tissue shadow also tells you if between C1 to C3, it is the large soft tissue shadow, there's there's swelling and edema or collection or hematoma, and you should be very careful about all this. Any loss of alignment, you should be aware and do investigate further. And flexion extension views are still controversial. However, sometimes, as you can see in the neutral film on the other side, that there you may not see the facet dislocation, and they can be evident, especially if they're less symptomatic. Sometimes additional radiographic films are available, and you can do them. However, CT scan in today's day and world is probably the best thing to do, because CT scan sensitivity is very high, and CT scan can almost detect 97 to 100% of injuries in the cervical spine and also in the head. So that is important to do. So your first choice would be CT scan, because of the ease of access, the speed, and quickly tells you the fracture pattern. Also, you can know about vertebral artery injuries, etc. So MRI is also done more routinely most of the time in our centers and in other centers, because it's also become now cheap and available. But CT scan is to be put on more first line of investigation after an X-ray. However, where you don't have any X-ray or CT finding and you want to exclude discal ligamentous injuries, you should perform an MRI scan, and stir sequences are suitable to evaluate the posterior ligament. Especially, we want to see if the posterior ligament complex is damaged, or there is edema, or there is swelling, or there is subtle fractures. So cervical spine clearance is very, very important, and the Canadian Spine Society and the American Association of Spine Surgeons have laid out very clear criterias and guidelines, and this should be all stuck in the casualty of every major hospital which is dealing with trauma. So from a vague symptomatic patient who has no problem, it's okay, you can rule out. But if it is symptomatic and if it is obtended, then definitely get more investigations, and CT scan is a modality of choice. Now, let me take you through some cases so that not to miss or what happens if you miss and how to deal with it. And that was my scope of discussion today. So this is, I'll start from this C1, C2. So this is a 53-year-old male, fall from stairs 2 months ago, had some injury to neck. He did not bother because he had minimum injury. And then after 15 days, he developed weakness in his upper limb, and later the patient developed gait imbalance. Planters were extended, so there was no bowel or bladder involvement. And if you look at flexion extension, this was a non-union of the odontoid, which is reducible. And this is his MRI pictures. There was some facet subluxation as well. And so this is a post-op. We did a C1, C2. This is a routine surgery, which we now do because we prefer to do this surgery. It is easy and predictable, and you can do a bone graft. And this is a 1-year follow-up. This is another patient who was actually managed conservatively, a type 2 odontoid fracture, but persistent pain made the patient come to us after 8 months. So here you have a non-union of odontoid after 8 months, and in these patients, it can be tricky to treat them, because they could be non-reducible, they could be soft tissue contraction could be there, and then you may have to do sometimes major surgeries. Here in this case, however, we did a C1, C2 wiring and did a fusion, and then this is a 3-year follow-up. However, sometimes you may have to do occipital-cervical fusion, or you may have to release anteriorly if the soft tissue is contracted. And I think Dr. Srivastava has nicely presented many times about this anterior release of odontoid fractures, delayed non-union or delayed union. Neglected odontoid fractures are the commonest, and they go frequently in non-union, and they're difficult reduction because of the contracted soft tissues. We tend to do mostly posteriorly, and if there is a problem, we do occipitocervical fusion with the decompression of C1. The other fracture, which is also important to keep in mind, is the hangman's fracture. So this is the other case, and this can also get easily missed. As you know, there are three types of hangman fractures, with the type 2 as well, in which there is an angulation with where we advise not to give any traction. So this is that case, and in this patient presented late as well, but had we did an anterior ACDF with bone graft. So in these patients, I tend to do bone graft without any cage or interspacer device. And this is the 10-month follow-up. This is another case. This is very interesting case. This patient had a T12 fracture for which she was operated. The neck was absolutely treated lightly, and this was the X-rays. And the patient had an hangman fracture, and this was the X-rays, flexion extension after a month. We don't do flexion extension views routinely. We only do on late presentation and those who are symptomatic. And this came to us after a month. And if you can see the CT scan, somehow the CT scan had not been done initially. You can see there's a fracture to the pedicle. There also has fractures of the C7 and C6 spinous processes. Since the patient had only neck pain and already had a spine surgery, there was a lot of reluctance, and there was no cord compression. And so I offered this patient a halo vest, and interestingly, this is a 1-year follow-up with which has healed. And then I recently asked them to send me some pictures of her movement. So this is an 8-year follow-up, which she has no symptoms, and she was reluctant to get an X-ray. She lives in Sonipat. This is another case, young man. As you can see, this is an inadequate X-ray, sustained injury to the head, lacerated wound was sutured. He didn't think much about it. X-ray spine, cervical spine was cleared. And this is why it is so important to get an adequate X-ray. After 4 months, the patient persisted neck pain and right arm weakness developed. He had another X-ray where you see a C5-6 facets perching, and this is the flexion extension. Sometimes I see very delayed facetal dislocations with facet fracture, which have gradually become almost fibrous union to union. And then those patients, I tend to leave them alone and counsel the patient of injury, which can precipitate neurological deficit. And depending on their views or their thoughts, then we would offer them surgery. This patient also had a right vertebral artery thrombosis, and so he was very worried because he had taken already many opinions, and there was an opinion that if we try to reduce this now, there would be a dislodgement of the thrombus and he could get a stroke. He was a young fellow, and he belonged to my school, though he's very young. And then he came to me finally, and I said, okay, the best thing I could do is, because he had a facet, one fracture on one side and a subluxar perched on the other side, I said, I'll fuse it in situ and let it go and see what happens. At least it will be safer for you. So this is what I did. This is a 1-year follow-up. And yesterday he was in Calcutta. I asked him to send him a picture from there. And so this is a fusion. As you can see, the facets have also fused posteriorly, and it is anteriorly fused, though there is some degree of local kyphosis. He is at the present asymptomatic and is fine. So neglected cervical facet dislocation in a developing country like ours can be a challenge. And unless you get them in the golden hours or early, and as we know from the study that Dr. Chavra did, that only 8 to 10% present within the first 24 to 72 hours, and 25% present late about in 3 to 4 weeks. Success of close reduction after that is possible. It happens, and we do it, but not as good as the fresh sub dislocations. In fresh, you can actually give an online traction and then get along and reduce it and do an anterior ACDF if by doing a discectomy. And most of the time, if the disc height is less, then you can do a posterior fusion. But when they come late, then you have two situations. You have a healed fusion, where you can actually discuss with the patient, and if you feel it is unstable, then you will have to do front, back, and front, and that is debatable which you start first, and there's a lot of personal preferences on this. And in unhealed, definitely you must go ahead and do surgery. There is very little really prospective class 1 evidence which shows that what should be done and how you should go about it. So it all depends upon your local situation and what you are comfortable with. In my practice, I tend to always go from the front and release the disc and put a cage spacer. If I don't get a reduction, then I will try all my best methods to do an anterior reduction by distracting and reducing. If I can't, then I would go posteriorly and burr out the facets and then come in the front and put an ACTF. I am aware that a lot of centers can go first posteriorly and then come anteriorly and do it. But this is personally up to the surgeon themselves. So whether you do posterior, anterior, or posterior is basically dependent on surgeon's preference and the disc, which is in the canal or not in the canal, and the disc height. So there are multiple views on this, and there is no standard view on this. So let's look at this case. Presented late, RTA was 5 months ago, neck pain radiating both the shoulders. Definitely this is unstable. And a lot of people would go from behind, burr out the facets, and then go anteriorly and put a spare, do a ACDF, put a spacer or put a bone graft and do an ACDF. Here also loss of vertebral artery flow. And this was his MRI scan, as you can see. But we did burr the facet from behind first, but I did not put any lateral mass. You can put lateral mass. A lot of people would do a 360-degree fusion, but I just did the burring, and as you can see, then came anteriorly and put a bone graft and fusion. So basically, if it is reduced and there's disc herniation, we would do ACDF. There's no disc herniation, then you can do a posterior fusion bilateral mass. If it is not reduced, then you will have to do posterior facetectomy and then ACDF. And if there's no disc herniation, you can do posterior facetectomy and fusion alone. So there are multiple reduction maneuvers you can do from the anterior approach. They have all been described in Benzel's book. You can see all the descriptive characters. You can give online traction, then use interspinous distractor, or you can put pins in the vertebral body, distraction pins, and the way the pins have been put in oblique fashion and then distract. That has also been described. Then once you have distracted, you can then push under control, you can push the facets down and reduce, and then you can put the cage or the bone graft and the plate. And if in the cervicothoracic junction you are not able to see the C-arm well, you can use a hook retractor and see as well. That is also there. So all the reduction maneuvers are described in this chapter by Benzel, and those interested or going to do, they should read this chapter with a lot of diagrams in them. Complications, of course, are there in these: hemorrhage, wound hematoma, damage to carotid vertebral arteries. You have to be very careful if you have a thrombosis, injury to recurrent laryngeal nerve, especially when there is a lot of traction and you're manipulating esophagus, trachea. You have to be very careful about this. And you can cause more neurological deficit if you are not careful about how much traction you are giving. And there is also a high rate of dysphagia associated. So you have to be very, very careful in these patients. So in summary, they are rare, but not so rare. So you have to be very careful when you see these patients in the casualty or emergency, and you have to teach your boys well. And unless the comprehensive management is initiated in timely fashion, there could be problems. Lack of awareness or lack of facilities in all the centers may be another factor. CT scan plays a vital role in the diagnosis. If at all you have any doubt, get a CT scan. Surgery remains the mainstay unless it is fused and the patient is counseled. And then there are difficult psychological and social rehabilitation problems, increased morbidity and mortality, and higher incidence of complications. And they may require longer hospitalization, additional cost, and adversely affect functional outcomes. So this is something, rather than treating it late, should not be missed. I thank you for your attention and happy to answer any questions.